Dr. Poch, thank you to IVUmed for allowing me to give this talk and trying to maintain some relationships across the world. Decided to kind of focus this talk on bladder cancer and some different aspects of bladder cancer that may be more relevant to the community in Rwanda than not. So since there's few people, we can actually probably keep it a little bit informal, so feel free to interrupt me. I think via Zoom, you can either just unmute yourself and yell at me, or you can raise your hand with that little raise a hand thing in the chat system, and we can address any questions. Some of it's going to be sort of informal talk, some of it's going to be data driven, and not spending a lot of time in Rwanda. If you guys have specific questions around specific things that you need more in-depth discussion on, I'm happy to address that also. And let me know if we end up having some technical glitches as well. I'm one of the urologic oncologists at Moffitt Cancer Center down in Tampa, Florida, and with a focus on bladder cancer too. So this is one of the areas of my specialty. And you can see Moffitt's actually behind me on the blue screen here. So this is our campus, although we're building a new hospital, which is going to be a surgical hospital, probably about a mile away as the crow flies. So just to dive into bladder cancer, so the focus will likely, or that I'll focus on today is going to be bladder cancer with kind of highlighting non-muscle invasive bladder cancer with BCG and responsive disease, as well as a radical cystectomy and kind of complications in and around radical cystectomy. So we'll kind of talk about non-invasive disease or low stage first, and then higher stage disease after. I was curious, so I pulled an article in 2019 looking at bladder cancer rates in Africa because I didn't know that much. Honestly, I was in Egypt last year giving a talk for the AUA, and Egypt and a lot of the North African countries have a much higher rate of bladder cancer than the sub-Saharan African or South African nations. Most of that's related to schistosomiasis, particularly in those North African countries with relating to squamous cell carcinoma. I have to say though, when I was in Egypt, a lot of the urologists there were talking about the fact that the rates of squamous cell cancers were going way down because they were actually doing a very good job of controlling schistosomiasis. And unfortunately, smoking is pretty prevalent in Egypt. The last numbers I looked at were about 20% of the population is actually active smokers. So they were describing the fact that the urothelial cell cancers were actually going up in Egypt and a lot of the North African countries, and the rates of squamous cells were going down. So it's kind of an interesting demographic flip, and maybe more relevant to kind of what we do in the United States. So again, based upon that study in North Africa, 10 out of every 100,000 people are at risk for developing bladder cancer, where in sub-Saharan Africa, the number is only about 5 out of every 100,000 people. So it's a little bit lower based upon that data. And you can see this is a table from that incidence. And up here, if you can see my arrow here, all of Africa is that rate of about 7, but in North Africa, it's much higher compared to East, which is the lowest. And you can see Rwanda is way down here, actually pretty close to the bottom of that list in terms of risk of bladder cancer. And this is also data looking at countries and the male to female breakdown here. And you can see Rwanda is here, actually at the lower end of that risk list for bladder cancer. So just kind of interesting data overall. I'm not sure whether that relates to smoking patterns or whatever it may be. If you talk about non-muscle invasive bladder cancer, we usually talk about this risk-based approach, which is by the American Urologic Society. And there's a couple different risk-based approaches to this, but I think that this is the easiest to access. There are some European guidelines as well, which look very similar, although have some slight differences. We look at low-risk disease, which is basically low-grade tumors that are small and non-recurrent. These are typically followed with cystoscopy. Intermediate risks are recurrent cancers that are low-grade TA, so that come back, or they're really large low-grade TA tumors or multifocal TA tumors. High-grade TA tumors that are less than 3 centimeters are also considered to be low risk, and this is one of the differentiating marks between some of the other guidelines, NCCN and European guidelines. And then high-risk disease is any high-grade T1, recurrent high-grade TA, high-grade TA greater than 3 centimeters, any CIS, any BCG failures, variant histologies, which include micropapillary disease or any tumors with lymphovascular invasion, So if you've got intermediate risk disease, we typically recommend either intravesical chemotherapy or induction BCG. If you've got high risk disease, we recommend pursuing with induction BCG plus maintenance therapy if available. When I looked into this a little bit deeper, it looks as though the BCG strain that you get in Rwanda is similar to actually what we have in the United States, with TICE being that made by Merck. So I'm not sure whether when there's global supply issues, if that's been a problem. Certainly in 2018, we had a significant problem in terms of access to BCG for our patients, which can affect overall outcomes and recurrence rates down the road. So if we talk about BCG failure, it's important to kind of define what that means. And a BCG failure is really a high-grade T1 disease at the first evaluation after induction BCG course, or recurrent high-grade TA or T1 disease within 6 months after adequate BCG therapy, or persistent or recurrent carcinoma in situ, or with recurrent TA T1 disease within 12 months. Essentially, what that boils down to, and the easiest way to remember this, is that BCG failure is really considered recurrent disease if you've gotten 5 out of 6 initial doses of BCG, and then either 2 out of 6 of a second induction course, or 2 out of 3 of a maintenance dose. So the important numbers to remember is this 5 plus 2. So 5 in induction, 5 out of 6 induction, and then 2 out of either 3 or 6 of that follow-up. And that, if you end up with a recurrence, is considered a BCG failure. So options for management of the BCG failure, the most common is radical cystectomy, or this is the highest weighted by most of the guidelines, because this is going to give you your best cancer control. So we have a low threshold to recommend radical cystectomy for patients that are kind of early BCG failures. Then there's some other options, which I'll talk about briefly: chemotherapy, which is single or double agent, and then some immunotherapy with pembrolizumab or adstiladrin. This was a pooled analysis looking at response rates from basically all different types of treatments, investigational, current chemotherapy regimens, published this year by Ashish Kamat, one of the urologists at MD Anderson. And you can see that if you've had 2+ BCG rounds, if you get treated with something else, that 12-month complete response rates is about 25%. So it's not that good no matter what you get. If you've had 1+ BCG and then ended up with a recurrence, if you've got 50% or greater of CIS, response rates are pretty poor. If you've got less than 50% of CIS involvement, then response rates can be as high as 50%. So that CIS component really affects the overall response rate in terms of how effective your additional treatment is going to be. There's a couple of different treatment options out there on the market. One of these is about to be probably FDA approved. There was published in Lancet Oncology last month, the article supporting this, so we'll likely see it, although I think the FDA has been slowed down because of a lot of COVID issues as well. Adstiladrin, or natafaragine, is an adenovirus vector, which basically gets interferon gamma inside the cells, the cancer cells, and attacks them that way. What they found, this is given as a in-bladder installation once every 3 months. So it's actually pretty easy to get in rather than doing every 6 weeks for BCG. So for patients that are traveling from a far distance, this is something that's pretty exciting because it's easier for maintenance therapy. For patients with 12 months for CIS, there's a 45 disease-free survival at 12 months. For papillary disease, it's a little bit lower. And about 20% of patients had some local symptoms associated with this. We also use pembrolizumab, which is an immunotherapy. Can you all still hear me? It looks like I got signed out.
I hear you.
Okay, thank you. I don't know why I'm getting a Zoom message that I'm signed out. Pembrolizumab is a checkpoint inhibitor. That checkpoint inhibitor is basically blocks this area
Excuse
here.
me, is there any way you can remove the sign-in?
Yeah, let me do that. Is that better?
All right, thank you.
For those not aware of how the PD-1, PD-L1 pathway works, the cancer cells actually have this PD-L1 ligand, which basically turns off the T cell, and basically downregulates that immune response to cancer. And so what the checkpoint inhibitors do is actually block that downregulation signal and then increases the activity of that T cell. So for patients with CIS, there's this Keynote 057 was published earlier this year in January and got early FDA approval for patients with CIS. And what they found was that about 46% of patients responded with a CR for at least 12 months with non-muscle invasive bladder cancer. So this seems relatively promising, although for people that have worked with immunotherapies given systemically, there is a risk of getting immune-related events associated with these. I just had a patient that was on getting this that was completely healthy, and she ended up getting antibodies towards her islet cells and becoming an insulin-dependent diabetic. So there's not, these medications are not without their side effects as well. So people consider them quote unquote immune therapy. It doesn't mean that you're not at risk for developing side effects. Technical errors here. Okay, this is a very busy slide, but a table just looking at some combination of chemotherapies for BCG unresponsive disease, and these are the agents here. So docetaxel, mitomycin C. So these are kind of sequential or administered together regimens associated with bladder cancer. And you can see there's very few patients in a lot of these studies here. 33. This is the largest study here, and you can see that there's kind of varying responses across the board regarding their disease-free survival rates. But again, if you go back to the Kamat paper, the overall response rates, if you look at kind of 12-month response rates, are only about 25%. At least in the US, there's a number of clinical trials that are going on looking at different delivery systems, either hyperthermic delivery systems, which mitomycin C is associated with and thought to get better penetration in a kind of a warmer bladder. There's something called a Terrace, which is this chemotherapy delivering pretzel that you put in the bladder, almost like a permanent, semi-permanent implant that kind of constantly leaches chemotherapy inside the bladder, which is the thought process that's supposed to give you kind of better levels within the bladder. There's photodynamic therapy, antibody drug conjugates, which we've seen even recently as enfortumab comes through for third-line therapy for bladder cancer in the metastatic setting, STING agonists, FGFR3 inhibitors. So there's a lot of different clinical trials that are ongoing right now in this space. And for somebody who looks like they're 25 years old, I've been in this business for about a decade, and you know, a decade ago, we didn't have any of these clinical trials that were occurring. So it's kind of an exciting time for at least somebody who treats bladder cancer. So I'll stop there and ask if anybody's got questions regarding management of non-muscle invasive bladder cancer. Okay. All right, so we'll switch gears a little bit and just talk about cystectomy for bladder cancer. I always like to start with this slide comes from Stein and Madabasher, looking just at survival outcomes for bladder cancer, although this is a talk more on complications. And you can see that the survival outcomes are really based upon T stage and N stage, and you can see that those are driving these survival curves here. This is the Stein data here, looking at organ-confined disease versus extravesical disease and lymph node positive disease. And you can see that the overall survival really trends with the recurrence-free survival. So basically, what you have for your bladder cancer is really going to dictate how your life is in terms of your overall survival. So the bladder cancer stage is really driving survival in these patients. And you can see a very big difference between those that are organ confined and those that are extravesical. We also know for cystectomy that the volume matters. And so for patients that have high volume surgeons as well as high volume hospitals that deal with cystectomy a lot, you can see here, this is a study that was done in 2014, just looking at the volume of patients in the hospital. You can see that those that deal with cystectomy a lot, this is in this white here compared to low, which is in the black here, have a difference in mortality, you know, by age group here. But you can see across the board, those hospitals and those facilities that are used to dealing with cystectomy patients have improved outcomes. And you can see here, again, this is low and high volume hospitals favor in terms of mortality outcomes. So how do we prevent intraoperative complications of radical cystectomy? This is a big operation. I usually counsel patients, at least in our hands. Here we do probably about 350 cystectomies per year as a group of about 5 urologists that focus on bladder cancer. The average hospital stay for us is about 6 days. And the overall complication rates, as similar to what's been published in the literature from the major centers, is anywhere between 30, 40, and 70%. That's for all complications. That's postoperative UTI, that's blood clots, DVTs, PEs. So it's a pretty morbid operation. And even if you look at the NSQIP data, and for those not familiar, the NSQIP is the National Surgical Quality Inpatient Database, which looks at 30-day outcomes. Cystectomy is associated with high morbidity no matter what. Even if you compare to liver surgery, esophagectomy, Whipple, cystectomy still ranks amongst the highest in terms of morbid and is comparable to those groups. And the reason for that is multifactorial. We're treating patients who are smokers, we're treating older patients. It's very rare to get a younger patient with bladder cancer. And these patients have multiple other medical problems, whether it's diabetes, whether it's cardiac disease. So the patients that you need to operate on, at least in our population, is not very healthy. But to prevent intraoperative complications, preparation is key. So you need to look at the films and you need to look at the patient's body. Typically, I tell the residents and the fellows here, what is the skin to fascia distance that typically will affect our ability to give a good stoma and a good conduit if we're doing an ileal conduit diversion. Where is the takeoff of the SMA? Is that high? Is that lower? What is that relationship to the pelvis? If you're going to try to do some kind of continent diversion, how much bowel do you have and how much tension are you going to have on the blood supply? Is there small bowel already in the pelvis? Some people, if you look at their films, will have this small bowel that's laying on top of the bladder, and you can say, well, it's probably going to be easier to get the bowel down to the urethra if we're considering doing a neobladder. And then where is a tumor located laterally? Is it resectable? Am I going to get into trouble in and around the lateral pelvic vessels, the common or the external or internal iliac vessels? Is that going to be a problem? And then we typically, for patients that are going to get diversion, we counsel them regarding the potential of not getting the diversion that they set out to get, meaning that if you're trying to schedule somebody for neobladder, you've got locally advanced disease or prostatic urethra is involved, or the mesentery of the bowel won't reach down into the pelvis, and that's going to be a challenge. You need to counsel patients preoperatively that they may end up with a different diversion than they originally planned for. So in the OR complications, and none of this is really 100% data driven, but this is kind of the experience that we have. If you've got a bowel injury, so let's say you're doing a cystectomy and you're opening and you end up with a bowel injury and it's serosal, typically we oversew that, or you have thermal injury using the bovicautery, that should be oversewn using a longitudinal type incision, or sorry, longitudinal type suture, just to cover the area. What you don't want to do is make a transverse incision and then narrow down the lumen of the small bowel or even the rectum. So the other place that this can happen is in the rectum as you're dissecting posteriorly along the back wall of the bladder. If you've got a full thickness, you can call for help with GI surgery. Sometimes they're not available, as occasionally happens at our institution. So you can do a 2-layer closure. Typically, that first layer is an interrupted layer with a vicryl or absorbable suture, followed by a more permanent silk suture that kind of oversews and lamberts that down, so you kind of get it closed on top. And then usually if there's omentum available, omentum is a placement of the abdomen, so it's always good to find some omentum and try to put it on top. I usually do this also for female cystectomies where we're closing the vagina, and we put some omentum on top to try to keep that a watertight closure, because sometimes female patients will complain about postoperative vaginal leakage because a lot of that ascites or reactive fluid in the abdomen peritoneal cavity will drain down into across those sutures and out. If you've got a vascular injury, obviously the most important is to hold pressure while you figure out where your bleeding is coming from, and then try to get proximal and distal control. It's most of these injuries occur during lymph node dissections, and it's harder to obtain control, particularly when you've got bleeding at the junction of the common internal and external iliac vein. Typically, that's where patients or surgeons get into the most trouble, I should say. Try to get as proximal and distal control as best you can. You don't necessarily need to get full control with the circumferential vessel loops. But even if you get sponge sticks on all of those vessels, that typically will give you enough control in order to put some stitches with a fluoroproline or any kind of fluoromonofilament permanent suture. I've done this before. You can actually sacrifice the internal vein and the internal artery with really pretty minimal sequelae because you're removing the bladder. The other thing that's important to note is to watch out for the obturator nerve. That nerve, it travels, obviously, as you know, kind of behind where those vessels are. And so if you're in a kind of crash situation where you have a lot of bleeding, it's important to recognize where that is so you don't get into trouble later with an injury. And then you have a low suspicion for Doppler if it's available. If you think you've caused an arterial injury and poor outflow, I've personally had to do this once. We had some bleeding, and I clamped across the vessels, unwittingly grabbed the external iliac artery, and then we kind of felt for a pulse afterwards and couldn't find a pulse in that. So we ended up calling our vascular surgeon in just to assess, and we actually raised an intimal flap by putting one of our clamps on to try to get control of bleeding. If you have some DVC bleeding during the dissection, I like to employ this catheter trick, which I'll show you here. So typically what I'll do is after I make my anterior urethrotomy here, prostate, bladder's coming out, I actually will grab the Foley. If I've got a lot of DVC bleeding, I can't really see where I'm going, I'll grab the Foley, bring it up behind where the pubic bone is, and then I'll grab this portion of the Foley catheter here, and the penis gets flipped up, and then you put a Kelly clamp across both, and this basically applies pressure anteriorly on the dorsovenous complex and kind of dries things up until you get your specimen out. Typically, once you get your specimen out, you can see a little bit better. So that's a nice trick that frequently we'll do in settings where there's uncontrolled DVC bleeding. What if the ureters can't reach? If the ureters can't reach, typically this happens with the left ureter because it needs to be transitioned underneath the sigmoid mesentery. This usually happens either from tumor purposes or from radiation, cervical, less so prostate. You can extend your conduit below the sigmoid mesentery. So you just make a really long conduit and it goes underneath the sigmoid mesentery. Or if you're doing neobladder with a chimney, typically there's chimneys you can make higher or lower, and those chimneys will reach up into you can get them as high as the renal pelvis, really. In a crash situation, you can give a cutaneous ureterostomy. Patients need to be thin in order to do this because otherwise you end up having some stomal issues. If you have a cutaneous ureterostomy, then you end up having potentially double stoma unless you flip sides. So that's another option, is flipping so the conduit comes out on the left rather than the right, is what we're traditionally used to. The other thing that occasionally has happened is the neobladder won't reach. So you measure out, you're doing a neobladder with your 65 centimeters of intestine, and then the neobladder won't reach all the way down to the pelvis when you're done. And then there's also a challenge despite preparation. So my first case ever, actually almost about 10 years ago, I created a neobladder, I couldn't get it down. Then I called my senior partner in to help me, and he said, well, is the table flexed? And I said, yeah, well, I routinely flex the table for all these cases. And he said, well, why don't you try to unflex the table? So I unflexed the table, and then miraculously the neobladder reached. So first thing to do if you have a neobladder that won't go down is to unflex the table. The other thing that you can do is you can ladder the mesentery of the bowel, and I'll show you what that looks like here. So this is essentially taking a portion of that the peritoneal surface on top of the bowel and the mesentery, and basically making these small incisions in it, which create this laddering effect. And this will give you additional length to try to get down. Now, it doesn't give you 10 centimeters, but it may give you, as high as 4 to 5 centimeters to get additional length down there. I typically would say that if you're borderline, you can try this activity, and before you kind of do all of your sewing, see how much length you get by doing this laddering maneuver on your mesentery. As I said before, cystectomy is a pretty complex operation with a decent amount of complication rates. And so this is just some data from 2010 looking at complications that lead to readmissions. You can see renal failure, dehydration, diarrhea, failure to thrive, metabolic derangements, sepsis, bacteremia, urinary obstruction, UTI. Typically what we're seeing, at least at our institution, is the things that bring people back are the failure to thrive, which you can see is about 5% here, dehydration, which kind of gets lumped together with our failure to thrive patients and UTIs. Normally what will happen is the patients, particularly who are going through chemo, and even some not, get a metallic taste in their mouth after surgery. I'm not really sure where this comes from, but when they go home, then the patients don't want to eat or drink anything. And so they end up in this spiral of not eating, not drinking, and then they end up getting failure to thrive with dehydration, which also can lead to AKI or acute kidney injury, renal failure. So that's typically what's bringing patients back to the hospital, is this kind of complex syndrome or urinary tract infection, which are hard to prevent. We don't typically prophylax patients with antibiotics after they get discharged from the hospital to prevent UTIs because we're worried about breeding resistance, but that's also consideration. We talked about volume as it relates to high volume hospitals and care and mortality. High volume hospitals and surgeons are actually pretty rare. If you look at the total number of cystectomies that are done, at least in the United States, you can see that these are the number of cystectomies logged per year. This is the number of urologists. So the majority of urologists who are logging cystectomies are doing 2 to 3 per year, or at least less than 5, whereas there's a very few number of urologists that are doing high volume surgery. But as I showed you previously, that actually matters in terms of outcomes. Switching gears a little bit to talk about urinary diversion, there are about 10,000 cases performed each year. The most common types of urinary diversions are ileal conduits, ileal neobladders, and right colon pouches. Urinary diversion is associated with well-described metabolic and functional consequences, but these can be a little bit variable. Continent diversions have a number of preoperative considerations. Some authors report that about 85% of people can get a continent diversion. In our experience, that's not the case. It's probably well under 50%, but some people like to push the envelope. So the objects of urinary diversion are to replace the bladder function, which implies typically low pressure storage and intermittent or complete elimination of urine. There's a number of ways to achieve that. They can be broadly characterized in heterotopic, orthotopic conduit, and continent diversions. And you can use almost any section of the GI tract to do this. And we'll talk about what the most common are, as you may be aware. You can use the stomach with particular considerations, colon, ileum here. You rarely use sigmoid colon or rectum these days for ureterosigmoidostomies. Jejunum is the one that shouldn't be used at all, given significant metabolic derangements. These are typically what we're doing for bladder cancer. On the bottom left here, you can see ileal conduit. That's harvesting about a 15 centimeter segment of the ileum, usually about 10 to 15 centimeters from the ileocecal valve, which is right about here. That gets brought out to the abdominal wall. And an ostomy appliance goes on there. So that is considered to be an incontinent diversion because you have no control over your urine. Other options would be to do a colon pouch, where we take a section of your right colon, and that right colon with a small section of the ileum, which is created into a channel to the abdominal wall. There's a kind of a flap valve here, which makes this a continent diversion. And usually the stoma is located similar to where we put the ileal conduit stoma. I often frequently tell patients that they're going to need to catheterize this every 4 to 6 hours for the rest of their days. This also has a slightly higher complication rate in terms of stomal stenosis, which I think I've got another slide on. And then there's neobladder, which is basically taking about 65 centimeters of the small intestine, usually ileum, reconfiguring into a reservoir and attaching it to the urethra. I typically tell patients that it's not really a new bladder, as the term would indicate, but it's more of kind of an intra-abdominal reservoir with voiding per the urethra, because the sensation to void is not your normal sensation to void that you have, because obviously the bladder is gone. So it's more of like a bloating feeling when you're feeling full, or some people don't feel anything at all and need to do time voiding. This is a slide that I always use for our residents in terms of how much bowel can you actually use to do something. And it really depends on how much bowel you're going to have left. So, and this is a slide looking at the risk of needing additional hyperalimentation, so TPN or nutrition through the vein, depending upon length of bowel that remains. So if you're in the 100+ range, you're likely going to, and based upon body weight, for patients that are smaller here by kilograms, if you're in the 80 to 100 range, you're probably at minimal risk for needing hyperalimentation or TPN after surgery. But the bigger you are and the less bowel you have, the more likely you are to have some nutritional deficiencies. And you can see here, if you only have about 20 centimeters, you have about a 50% probability. So when we're doing these operations, I always like to document how much bowel is left that we're not using. And then also that helps indicate whether we have enough to do a continent diversion. So if we're planning to doing a neobladder, we want to make sure that we're not going to put the patient into a risk for having nutritional deficiency or potentially for diarrhea. So these are very testable things that we end up seeing in a lot of our exams for the residents and fellows. The available bowel segments, as I already talked about, stomach, jejunum, ileum, and colon. The stomach is okay. It's typically used for something called gastrocystoplasties in pediatric cases, not necessarily for what we do. It's less permeable, and this is the only one that would cause a metabolic alkalosis. But you can also get hemolytic uremic syndrome. So we typically see patients who have some bleeding associated with the use of the stomach. Jejunum should not be used because of the severe electrolyte disturbances. And if you need to use it, only a distal portion should be used. This is something that we do not recommend at all. Ileum and the colon are the most common segments used for urinary diversion. And typically because you get adequate length, you've got a mobile mesentery, and surgeons are usually familiar with these bowel segments more so than some of the others. There's two main types of neobladders that we see in the literature that have been described. One is called the Studer, which you can see here as number C, which is basically making a reservoir with a single chimney where both ureters come in. And then there's also the Hauptmann, which is this W where both ureters come into this W, and this gets folded over. Both are very viable options at our institution. Basically, half the surgeons do a Studer, half the surgeons do a Hauptmann neobladder. This is a depiction of the right colon pouch. You can see here, right colon is harvested along with that section of the ileum. The ileum here is tapered down to make that catheterizable channel, and you actually kind of imbricate it a little bit in order to get that valve associated with it. And you can see implantation of the ureters both in the pouch. For pouches, yeah, they're probably the least common diversion that's done. And you can see here the complication rate just associated with the stoma or the getting nipple stenosis is high. So if you think about the overall risk of this operation in terms of the diversion, you know, that with complication rates between 40 and 60%, I typically tell patients or kind of drive them away from this a little bit if they're not great candidates, because there's extra complications associated with pouches. And typically that's either stoma or nipple stenosis. You can have some ureterointestinal stenosis, which you can see for any type of urinary diversion. And then you can also get this pouch calculi or stones within the pouch because of the nature of the pouch. It's not really drained by gravity like a neobladder, but it's drained by kind of siphoning urine off through that catheter drainage. So you can see both pouchitis as well as pouch calculi. So in terms of the overall options for urinary diversion, this is probably the least done because of the complication rates and kind of least favored by a lot of the urologic oncologists if there are other options available. If you look at neobladder, one of the main questions is how do neobladders function in terms of urinary control? And this was published in 2016. The daytime control rates are pretty good, particularly when you hit that 12-month period for neobladders, with over 90% of patients having good daytime control. Nighttime control is less good if you think about you're removing the internal sphincter, and therefore most of your urine control comes from that external sphincter. And when you're asleep, you've got significantly less control over that external sphincter. And so it's that's where we're seeing some of these decreasing in the continence rates during nighttime. So a lot of patients will either put on a condom catheter or wear a pad in their underwear during the nighttime so that they don't have significant soiling of any of their sheets or bedclothes. There's some contraindications to continent diversion. Renal function, continent diversions are contraindicated in patients with creatinines greater than 2 or GFRs less than 40, or patients with some form of bowel dysfunction, either short gut syndrome, IBD, Crohn's disease, prior abdominal radiation, or colon polyps and cancers. It's interesting, I've done a number of cystectomies in patients with Crohn's disease, and actually the segment that you use for the ileal conduit actually, when you evaluate these, is less affected by the Crohn's without stool passing through. So surprisingly, we see less of an issue, at least in the conduit portion of the Crohn's disease. Now, these patients end up with malabsorption, so it's kind of contraindicated to do neobladders because you don't want to decrease their overall absorption and nutritional status. Prior abdominal radiation is not a hard stop for doing any kind of continent diversion, but it just needs to be kind of taken into account, and the bowel segment needs to be evaluated to make sure it's healthy. And urinary functions for patients that have baseline incontinence, typically giving them a neobladder is not going to improve their urinary health and quality of life. And so doing a conduit where they can get better control is more appropriate. We can see some metabolic derangements that occur, and these can be either electrolyte abnormalities, abnormal drug metabolism, osteomalacia, growth retardation, recurrent or persistent infections, urolithiasis, gastrointestinal malabsorption. The most common metabolic abnormality that we see is this hyperchloremic metabolic acidosis, and this results from excess ammonium chloride absorption across the lumen of the bowel segment. This can be really effectively managed with alkalinization with oral sodium bicarbonate. When you replace this, though, this can be a little bit of a big salt load, so it just needs to be taken into account. Some patients with CHF can't tolerate this oral sodium bicarbonate if you need it. And there are some studies that say that about a third of patients with neobladder need bicarbonate replacement. We typically would refer patients to a nephrologist, but you can manage this on your own if you're checking routine CMPs. And you can also see reports of ureteral strictures, 27% renal deterioration. I'll show you what that looks like, chronic pyelo, and 3% metabolic disorders. And again, as we talked about, these are testable metabolic abnormalities. Ileum and colon, which are most commonly used, causes hyperchloremic, hypokalemic metabolic acidosis. Stomach is the only one, again, that causes this alkalosis that we see. And jejunum essentially shouldn't be used because it causes such severe metabolic derangements that it's hard to recover from. So we talked about sodium bicarb here. We usually give 1 to 2 grams 3 times a day, but it is, again, associated with that large sodium and fluid load, as well as can be associated with some flatulence, so it's uncomfortable for patients. You can also use sodium citrate, but this one tastes bad. Some people have used some nicotinic acid or chlorpromazine also when sodium overload is problematic. And again, these are patients with CHF, pulmonary edema, hypertension. If you're correcting an acidosis, you should probably give some potassium as well. And then calcium supplements should also be considered because that chronic metabolic acidosis can cause osteomalacia and osteoporosis. These are some long-term complications associated with cystectomy. You can see 5-year incidence estimates, ileoconduit and continent diversions, stoma problems, hernia, wound, urinary obstruction, urolithiasis, fistula, metabolic acidosis, renal failure. So these are all something. So this is a lifetime of outcomes for cystectomy patients. Again, you're kind of re-altering their internal configuration. And so you're at risk for developing a lot of problems down the road. And they usually tell patients that when they're going through this operation, that their recovery should be an upward sawtooth. It's never going to be a straight line like a hernia repair where you have the operation and things just kind of get better over time. This kind of looks like this. As long as things are headed in the upward direction, though, that's what we want to see, is that upward trajectory. But there are peaks and valleys in their recovery of this, even out to 5 years. Patients also, as I said before, are at risk for developing stones. These are typically calcium oxalate stones that we see can be from malabsorption associated with this, with decreased urinary citrate levels and the higher risk of urinary phosphate and sulfate. And then you can see some pouch stones again in these continent diversions, and that typically occurs because of stasis of urine within the pouch and it's not completely drained. Again, we talked about GI malabsorption. Diarrhea can be problematic after urinary diversion. You can start cholestyramine with 4 grams BID. That can bind to bile salts and help reduce diarrhea and increase your fiber intake. And then you can also start things like Imodium, which is loperamide, 4 milligrams for refractory GI issues. And we're seeing that obviously more in patients with continent diversions, either colon or neobladder. It looks like there's some questions here in the chat, maybe. All right, I will address a question in the chat momentarily. I think we're close to finishing up. Let me move this out of the way. And just a final note on long-term renal function outcomes after cystectomy. This was a study that was out of the Mayo Clinic looking at CKD or renal insufficiency after surgery. And you can see both for incontinent and continent diversions, you can see a decline, basically an equal decline in urinary function. So I tell patients to expect to see their urine, their creatinines to go up and the GFRs to go down after surgery. It's just the nature of that kind of either chronic obstruction or urinary infection. So to address questions in the chat, we typically will see patients, depending upon their type of diversion, after cystectomy at specific time intervals. For patients with conduits, they're usually getting seen about 2 weeks after surgery. We usually do this operation and close the skin using skin staples. And so therefore we remove the skin staples usually at that 2-week mark with also pulling out ureteral stents, which we use to stent open the anastomosis between the ureter and the intestine. Then patients are typically seen a couple of weeks after just to make sure that they're doing well and their pathology is back. We usually will review that with them, usually at the 4 to 6 week mark. And then depending upon pathology, they usually get seen every 6 months for about 5 years at least, and then referred back to their local doctor for further evaluation and metabolic follow-up. For patients with neobladders or any kind of continent diversion, it takes a little bit more intensive, immediate experience with management of all their tubes and drains. So typically those neobladder patients will come back for their 2-week appointment, we remove the staples, and then they usually have stents that are exiting their abdominal wall with an ostomy appliance on top. So we'll pull those stents out at the 2-week mark, and then patients will typically drain most of or all of their urine from their urethral catheter if it's a neobladder. Then they'll come back a week later and we'll pull the urethral catheter out. And then they get logs and make sure that they're voiding well, and we teach them how to catheterize if they're not emptying. And so then they'll come back a week after that with their neobladder logs and let us know how they're doing in terms of voiding volumes, and if they're doing self-catheterization, what their volumes are to make sure that they're emptying well and not going to end up into trouble. And then they go back on the routine cancer follow-up if it's a cystectomy for cancer purposes. So depending upon their pathologist, they'll be seen 3 to 6 months with repeat imaging and labs, et cetera. Any other questions? You can, I'm not sure if you're allowed, if you have the access to unmuting your microphone, or you can put them in the chat as well. Well, if there are no other questions, I want to thank, what would be advice, low resources for countries where your oncologists are very few, and where's awful BCG ties? So the answer is we don't have a lot of, so the question is for nobody that can see the chat, what would be your advice for low resources country where Euro-oncs are very few and where it is also difficult to get BCG TICE? It is repetitive TURBT an option for this category? The answer to that is we really don't know. For patients, it really probably depends on what the pathology is. So if you don't have access to BCG or intravesical chemotherapies, if they're expensive or they're just not available, you could consider doing repetitive TURBTs. And I imagine over the next probably year or two, we'll probably start to see some data because of the BCG shortage that we had, at least in the US, about trying to manage some of these cases. The 2 bits of information that I would probably say is that if you've got patients with high-risk disease, either high-grade T1 with lymphovascular invasion or some kind of variant histology, micropapillary or plasmacytoid, then I think doing an early cystectomy is probably going to give you better cancer control than repeat TURBT. It's probably, obviously you're talking about, as I just spent the past 40 minutes talking about, it's a pretty morbid procedure, but you're probably from a cancer perspective going to get a better outcome with better long-term risk. If you look at bladder perforation data, so if you look at the risk of making a hole in somebody's bladder after TURBT, that's associated with repeated TURs, multiple repeat TURs. And so the more you TUR, the more you are at risk for perforating somebody's bladder. So it's a challenge. On the flip side, though, there is data from Memorial Sloan Kettering and Harry Herr for patients with muscle invasive disease who you do a resection on. When you bring them to cystectomy, about 10% of them will actually have no recurrent disease in their bladder. So those patients were essentially cured with their TUR alone. So on the flip side, if you can get good control, then that may also be an option for you, with the understanding that they may end up with recurrences, which need to be managed. So both are options, but I would say that for the higher risk patients, maybe early cystectomy, early bladder removal is going to give you very good oncologic control. How do you manage a patient if the tumor is not so the question is, how do you manage a patient if the tumor is not resectable? In the TUR setting, so for tumors that we can't scrape out via TUR, transurethral section, then typically we're recommending cystectomy. I've done a number of these for low-grade tumors, so that's an option for localized disease. If you've got tumors that are locally extending locally extensive beyond where the bladder is, either into additional structures or to the rectum laterally. It really depends on what that scan looks like. We've done some total pelvic exenterations for patients with bladder cancer that had rectal involvement. We've done resecting some vascular structures. We have the fortune to have chemotherapy at our institution also. So some of these patients get downstage with chemotherapy after that initial scan where it doesn't look like they're resectable, then they get some chemotherapy. But there are some patients who you just cannot control surgically, and those patients need to be palliated. You can do palliative conduits on them, and you can radiate their bladders if we think that you're going to get into more trouble than not with doing a cystectomy on them. Any other questions? Follow-up question, what if a patient comes in with a big tumor obstructing the bladder neck? Big tumors obstructing bladder necks and you're unable to access the bladder for resection with scopes, that can be certainly a challenging case. We have done procedures where if we can't get into the bladder, then we have done basically suprapubic tube access and put in resectoscopes through the suprapubic tube track, or done an open cystotomy and done TURs that way, or excision of tumors. So I wouldn't call it an anterior approach, or an antegrade approach, but I think access through a suprapubic incision is not unreasonable. What considerations to take when choosing from orthotopic neobladder and ileal conduit? The first consideration for all of this is, I think, whether the patient's physiology will accept it. So the first question is their kidney function good enough to do it? Do they have any of those other issues where they've had multiple abdominal operations, they're not going to have enough intestinal segments to do something with? They've had a history of colon cancer, or they're at risk for developing nutritional deficiencies. So those are the kind of common questions that we come up with. Then the second question is, are they willing to catheterize themselves? Because if the neobladder is not going to drain, they're going to have to empty it out somehow. So do they have the resources? Do they have access to catheters? Do they have the dexterity of their hands? And if you're doing an 85-year-old female who may have arthritis, can she catheterize herself versus a 40-year-old male who can easily kind of slide a catheter in their penis? And are they willing to do it? So some patients aren't willing to put a catheter in their penis. They look at you like you've got two heads, saying, I have to do this, I have to put a catheter in my penis. And so they're not willing to do that. So those are some of the considerations regarding neobladders and conduits. So as I said, some of the surgeons across the country will report rates as high as 85%, but I think the practical aspect of this is that it's probably a lot less if you look across the country. Can partial cystectomy be considered in some cases? Absolutely. Partial cystectomy is a great option for some cases. Usually what we like to do is make sure that there's no concomitant carcinoma in situ and the rest of the bladder. So if you've got patients that have a solitary tumor that is in a location that's amenable to a partial cystectomy, I think that's a good option. Normally what I'll do is I'll do a number of things. I will scope them, make sure that they don't have microscopic CIS throughout the rest of their bladder. And then I'll also measure their bladder capacity, because if you're starting out with a low bladder capacity and then you do a partial cystectomy on somebody, you could obviously, if you're leaving them with a 200 cc bladder, they're going to be miserable from a quality of life perspective. So that's usually what we do. And then the tumors that are best amenable to those partial cystectomies are either anterior tumors or tumors located at the dome, where you can kind of get a nice circumferential resection without risk of injuring nearby structures, trigone of the bladder, et cetera. But very reasonable option for small to medium sized muscle invasive tumors with where you're leaving adequate capacity. These are great questions. So it looks like we're running up against the time challenge here anyway. So I want to thank IVU, and I want to thank the audience for both participating, their time. I know time is valuable these days. Look forward to interacting, maybe potentially on a personal level with a lot of you in the future. And again, thanks to IVU as well. Hope everybody stays safe and healthy out there.
Thank you very much.
Yeah, thank you so much, Dr. Poch.
Am I in charge of ending the meeting?
I'll end it, but thank you so much for presenting.
All right, no problem. Thank you very much. Take care,
Yeah.
and happy holidays, everybody, too.
Yeah, thanks. You too.